Hello and welcome to Talking About Tumors with Ryan and Ryan. Once again, just Ryan Holstead today. Going to close out our discussions on the head and neck squamous cell carcinomas. So the first part of this discussion was looking at the workup for head and neck squamous cell carcinoma, the differences between some of the subsites of interest, staging approach, and the indications for adjuvant chemotherapy combined with radiation. Today we're going to be talking about locally advanced disease. We'll take some time to discuss nasopharyngeal carcinoma and then close out with metastatic or incurable recurrent disease. One aspect I forgot to mention during the prior discussion was regarding the discovered cervical lymph node. So you will run into a situation from time to time where a palpable cervical lymph node is identified, it's biopsied, it shows squamous cell carcinoma. However, on workup, there is no clear sign of an origin. Examination for these patients should include a detailed cutaneous exam to make sure there's no squamous cutaneous primary, as well as pan-endoscopy, including laryngoscopy, as well as an upper endoscopy to evaluate for any other sites where the squamous lesion might have begun. It is not an uncommon situation where the primary is never identified, and then this is treated definitively as a TX node-positive head and neck cancer. So moving into locally advanced disease. So this is going to be our stage 3 and stage 4, larger primary tumors or significant lymph node involvement. Cancers of this stage have an increased risk of local and distant failure. And in tumors that have N3 disease, these can carry up to a greater than 30% risk of distant spread, even with definitive management. For these patients, you are going to be more likely to want to consider a CT chest to rule out any lung metastases. And more often, providers, when having this available, are going to use a PET scan just due to the increased sensitivity of this modality. In some patients with stage 3 or stage 4 disease, surgery may still have a curative approach, but this could be at the cost of extensive regional morbidity. Often these T4 tumors are invading local structures, and surgery can be quite morbid and lead to long-term quality of life complications. This has led to an interest of trying to see if definitive radiation or concurrent chemoradiation may be more preferential to limit long-term morbidity. You're going to hear the terms of organ preservation when we talk about using radiation definitively. It's important to differentiate organ preservation does not necessarily mean functional preservation, and giving definitive radiation can still lead to significant toxicities in the local level, even if the organ remains in place. However, there's a greater chance of preserving function of something such as the vocal cords if we're giving radiation there versus surgically removing them altogether. Probably the best area where the difference between surgery and radiation has been studied is with laryngeal cancer. Because in locally advanced disease, surgery often can necessitate a permanent tracheostomy and loss of voice. In early stage 1 or stage 2 disease, surgery may be able to be minimally invasive or definitive radiation may be considered. In stage 3 or stage 4 disease, the efficacy of a definitive approach was best shown in a landmark trial run by the Veterans Administration in the United States. This published in 1991. This was a randomized controlled trial that was looking at the comparison of surgery followed by adjuvant radiation compared to definitive chemotherapy followed by radiation strategy. This was prior to the concurrent chemoradiation era, and this trial used an induction chemotherapy regimen with 3 cycles of cisplatin and 5-FU, 5-FU being given over 4 days, every 21 days, for 3 cycles prior to the definitive radiation course. This trial was powered for disease-free survival and overall survival. It included 332 patients that were randomized. This study found an equivalent overall survival at 2 years, regardless of which arm patients were randomized in. And in 64% of the patients, who received the chemotherapy followed by radiation, 64% were able to avoid the need for laryngectomy. So although limited only to the larynx, we've at least seen good quality data to support a non-surgical approach in the locally advanced setting for these patients. As a better understanding of concurrent chemoradiation came to light, further studies looked at laryngeal cancer to see whether or not the VA study was the optimal regimen. And one noteworthy study was the RTOG trial 91-11, which included stage 3, stage 4 laryngeal cancer. And this randomized patients 1:1:1, so this was a 3-arm trial, to the VA regimen, so cisplatin and 5-FU followed by radiation. In one arm, they were randomized to concurrent chemoradiation with a cisplatin regimen, 100 milligrams every 3 weeks, as we've discussed previously in the adjuvant trials, or in the third arm to radiation alone. So keep in mind the initial VA trial did not look to see whether radiation alone was effective. So this was studied in this trial. The study was powered primarily for overall survival, with a secondary outcome of larynx preservation. This study had both a 5-year and a 10-year analysis. First of all, looking at overall survival, they found similar overall survival in all 3 arms. So the induction chemotherapy arm had a 5-year overall survival of 58%, the concurrent arm had an overall survival of 55%, and the radiation alone was 53%, no statistical difference. And at 10 years, overall survival was similar with 39, 27, and 31% respectively, overall survival. Looking specifically at larynx preservation, so in patients who remained alive, those that were able to not undergo a laryngectomy, this was greatest in the concurrent chemoradiation arm. So at 5 years, the induction chemotherapy arm had a 70% rate of larynx preservation. This was improved to 78% in the concurrent chemoradiation arm and was the lowest in radiation alone at 65%. At 10-year follow-up, we see that the rates of larynx preservation remained relatively stable in the chemotherapy-containing arms with 67.5% and 76% respectively. However, a steep drop-off was noted in the radiation arm with 33% of patients having larynx preservation at 10 years. So the take-home here was that it did not appear that induction chemotherapy was significantly better than concurrent chemoradiation. And in terms of overall survival altogether, all 3 options were equivalent. But to preserve the larynx, the best options were chemotherapy, including regimen, and potentially the best was with concurrent chemoradiation. Now, these 2 studies I mentioned are not the only studies that have looked at the incorporation of chemotherapy with radiation as a definitive approach in locally advanced disease. We do not have time to go into all the trials. When looking at all of the head and neck squamous cell carcinomas, excluding nasopharyngeal carcinoma, there have been more than 100 trials published to date. So rather than going through these one by one, we've fortunately had the advantage of a meta-analysis that has now published out on multiple questions that are relevant to the field. This is called the MACH-NC analysis, so MACH-NC, the meta-analysis of chemotherapy in the head and neck cancers. And this meta-analysis used both trial-level data as well as individual patient data. So they're able to get the individual outcomes for each patient on the trials, which is a very powerful way of doing a meta-analysis. And one of the questions that's looked at is whether or not there could be an overall survival shown with chemotherapy versus radiation alone. Remember, the RTOG's trial did not show this, but this was a single trial with a few hundred patients. When we're looking at the thousands of patients, we did see an improvement in overall survival, slight, about 4% overall compared to radiation alone. Now, this absolute benefit did appear to be improved when looking at patients with concurrent chemoradiation, where the absolute benefit did increase to about 8%. So it's possible that induction chemotherapy followed by radiation was not as effective as the concurrent chemoradiation. The study also found approximately 30% of patients who had a chemotherapy-containing regimen, whether that was induction or concurrent chemoradiation, did have a 30% chance of a complete response. And 90% of the patients had a major response, so that this was a fairly effective treatment that gave at least some radiographic benefit in most patients. Now, the natural question that arises, and what remains a very controversial issue today, is whether or not using induction chemotherapy followed by concurrent chemoradiation with chemotherapy is able to further improve on outcomes in these patients. Unfortunately, the quality of trials that have been looking at this question are fairly limited. We will discuss where this has at least shown some benefit, specifically for the patients with nasopharyngeal carcinoma. But first, we'll turn to the data in the non-nasopharyngeal carcinoma settings. And there's some great reviews out there. One by Dr. Gawali, published in 2016, and a nice review by Dr. Gall in Oral Oncology, published in 2019. We'll link to those in the show notes. I think those show both conservative and more pro-induction chemotherapy followed by concurrent chemotherapy hypotheses. I think the first important thing to mention is we've never been able to show overall survival adding induction chemotherapy prior to concurrent chemoradiation that includes cisplatin. Most of the earlier trials looking at this did use the VA regimen with the cisplatin in 5-FU given for 3 cycles. Clinical trials that have looked at this question did have variable uses of concurrent chemoradiation. I'm not entirely sure why, but possibly to limit the cumulative cisplatin exposure. But I've seen some of these trials using carboplatin-based regimens or taxane-based concurrent chemoradiation occasionally. However, the majority of the trials that have been really even combining these regimens together have really been more comparing different concurrent chemoradiation regimens or different induction regimens. Proponents in favor of an induction followed by concurrent chemoradiation regimen often will point to the TAX-323 and TAX-324 trials. These are two clinical trials that looked at intensification of the induction chemotherapy regimen. The TAX-323 trial did not have a concurrent chemoradiation arm. It was looking at two different induction regimens followed by radiation alone, whereas the 324 trial used a carboplatin-based concurrent radiation using an AUC of 1.5 weekly. These trials specifically were looking at adding docetaxel to the cisplatin and 5-FU regimen, and in both trials they did show an improvement in overall survival, with the 324 trial showing 5-year overall survival improved from 47% to 52%. This was at the cost of increasing neutropenia and mucositis, which is in addition to what was already pre-existing with cisplatin and 5-FU. One of the limitations with this study, of course, is the utilization of carboplatin during the concurrent chemoradiation component raises the question of whether or not using a cisplatin during the concurrent chemotherapy component may have diluted the added benefit of the induction chemotherapy. As one of the follow-up mock-NC meta-analyses, they did find that the induction chemotherapy also included benefit to limit distant and local failure rates. However, as I mentioned, this meta-analysis was unable to find an overall survival when adding this regimen to a concurrent chemotherapy regimen. So there were a few trials that did try to look at this question, so with or without induction chemotherapy followed by concurrent chemoradiation. However, unfortunately, these trials had some flaws. The two more major ones were called the Paradigm trial, PARIDIGM, and the Decide trial. However, both of these trials had difficulties with accrual and had to close early. There was also a French trial and a Spanish trial looking at the same question. I'm going over these trials a little bit briefly because there's some added complications that make this even more difficult to analyze, which is not necessarily germane to our discussion anymore, as some of these trials had used cetuximab as a radiosensitizer. This had been an increasing area of interest where instead of using cisplatin, cetuximab was used instead. This was based upon improvements in progression-free survival and overall survival incorporating cetuximab in the metastatic setting, as well as preclinical research that has shown cetuximab to be a potential radiosensitizing agent. The reason why I'm not going to go into this in more detail is we've since had multiple trials show that cetuximab is inferior to a cisplatin-containing regimen and would not be considered a standard of care approach now, as although it's inferior to cisplatin, the level of toxicity is actually quite similar to using cisplatin. So despite overall survival not being convincingly shown, adding an induction regimen to a concurrent chemotherapy regimen, the outcomes of the TAX trials showing that this does at least have some increased efficacy when you intensify an induction regimen have led providers to still prefer this in areas, but you will likely see differing opinions in practice depending on where you're training. And I highly encourage you to review the pre-existing literature, the prior findings from the MACH-NC meta-analyses to help make your own decisions. The one area that does sort of go in favor for an induction followed by concurrent chemoradiation regimen was shown in a recent clinical trial published in 2019 in the New England Journal for nasopharyngeal carcinoma. Now, this is a different disease, and nasopharyngeal carcinoma is associated with EBV. It's geographically distributed in southern China, Southeast Asia, northern Africa. It tends to arise more often in younger patients and is a chemosensitive malignancy. 70% of the patients with nasopharyngeal carcinoma do present with locally advanced disease, likely due to the ability for it to spread locally prior to becoming symptomatic. Although with good responses and overall survivals greater than 70 to 80%, 25% of patients will recur by 5 years when given concurrent chemoradiation with cisplatin alone. And distant recurrences are responsible for the majority of death, which, given that we know that induction chemotherapy does reduce distant recurrences, and given that these are young patients who have a much bigger impact on their overall survival, if we can cure it without recurrence, there was good argument for this trial to be run looking at these patients. So this study was an investigator-initiated trial, which we don't see too often anymore. This was not a trial designed and run by a drug company, and that's because it was looking at old-fashioned regimens. Old-fashioned regimens, and the makers of those chemotherapies would not have the funding to run a clinical trial. So this was likely grant-supported, university-funded. This trial included stage 3 and stage 4 patients with nasopharyngeal carcinoma. It did exclude some patients with stage 3 disease who were thought to have a primarily locally invasive disease without lymph nodes, which could have been treated with surgery alone. They randomized patients 1-to-1 to an induction chemotherapy regimen using cisplatin 80 milligrams and gemcitabine 1,000 milligrams, the gemcitabine being given on day 1 and day 8, every 21 days for 3 cycles, followed by concurrent chemoradiation using cisplatin 100 milligrams per meter squared every 3 weeks for a total of 3 cycles during the course of radiation. And the control arm used what was the standard of care for this disease, which was the concurrent chemotherapy radiation regimen. So it was powered for disease-free survival with the secondary outcome of overall survival. And they randomized approximately 240 patients to either arm. The average age of these patients was 46, which is typical for this disease. 75% were male. Most had stage 3 or 4A disease. Only a few had stage 4B. And nearly 100% of the patients were able to complete the regimen. So keep in mind that this is fairly intensive using cisplatin at these doses. And this is something that's unique about the nasopharyngeal carcinoma, where it is younger, healthy patients than what we might see with other head and neck cancers. So it may be difficult to extrapolate a lot of these results to the other head and neck malignancies, but they did find a significantly increased recurrence-free survival and overall survival. So looking at the primary outcome of recurrence-free survival at 3 years, this was increased with 85% in the induction arm versus 76% in the control arm. And at the final overall survival analysis, they did find 5-year overall survival now was improved with 88 versus 79%. So a 9% improvement in overall survival. This was at the increase of some additional neuropathy, with grade 1 and 2 neuropathy at 9% versus 2% at 5 years. So once again, this is the one induction chemotherapy followed by concurrent chemoradiation that did show an overall survival benefit. This may be impacted by these being young, otherwise very healthy patients, or may be related to something unique in the EBV-associated nasopharyngeal carcinoma. In addition to the studies looking at induction chemotherapy for these patients, there have been attempts to look at alternative concurrent chemotherapy regimens. During our last discussion with the adjuvant chemotherapy, we did discuss the studies that have shown non-inferiority of weekly versus Q3 weekly cisplatin, and that this may be considered an option in some patients, especially those who the toxicity of the Q3 weekly dosing may be of a concern. And a few regimens have been studied, although none have been ever shown to be superior to cisplatin. One regimen in a French trial looked at the combination of carboplatin and 5-FU, both given for 4 days in a row, comparing to radiotherapy alone. And this did show an improvement in disease-free survival with the chemotherapy arm. There's at least one trial looking at a weekly carboplatin with an AUC of 2 and paclitaxel 45 milligrams per meter squared compared directly to cisplatin concurrently with radiation. This was specifically in nasopharyngeal patients and was designed as a non-inferiority trial. In this study, they allowed for a non-inferiority margin to allow for an increased 25% risk of death, and they did meet non-inferiority. However, allowing for 25% increased risk of death prior to showing inferiority is a pretty wide margin. So I'm not sure if this really shows equivalence beyond just efficacy. There's also been some studies looking at docetaxel, which have also shown improvements compared to radiotherapy alone. As I previously mentioned, there had been an arc of incorporation of cetuximab into these concurrent regimens. This also has shown superiority radiation alone. However, in repeat trials has been inferior to cisplatin. It also has shown increased risk of death in patients older than 65 and hasn't reduced toxicity. So there aren't any great situations where cetuximab would be preferred where cisplatin is contraindicated. So the bottom line as far as the alternative agents go is that cisplatin would be our preferred agent at this time, either 3 weeks or weekly. And if there's a strong contraindication to cisplatin, such as heart failure, renal dysfunction, you may reach for an alternative agent such as the carboplatin-based regimens or docetaxel. However, it's important to keep in mind if your reason for not choosing cisplatin is from overall frailty or patient functional status, you may be just as well to use radiation alone, as our margins for efficacy do get smaller when we use less preferred regimens, and even lower still when we're dealing with patients with marginal functional status. As we mentioned, unfortunately, these patients have a high risk of recurrence, and recurrences may be local or metastatic. If the recurrence is local and the patient has had radiation previously, you may attempt to see if salvage surgery is an option. If a patient has had a surgical approach initially and has had local recurrence, definitive radiation may be an option. Should a definitive salvage option not be available, the best disease-directed therapy available would be systemic therapy. It's important to keep in mind that symptomatic management and palliative care is going to be very important for these patients due to the location of the disease, risk of dysphagia, regional pain, as well as local invasion into nerves, which can cause significant pain, risk of blood vessel invasion, which may cause thrombosis, venous stasis, or even the risk of acute hemorrhage are significant complications in these patients. And coordination with palliative care can help improve quality of life significantly, especially as the response rates of systemic therapy are going to be marginal, especially in pre-treated patients. Not to mention these patients have often had previous radiation or surgery and have pre-existing toxicities, which are also compounded by locally recurrent disease. In terms of systemic therapy, just to get it out of the way, nasopharyngeal carcinoma is treated a bit differently than the other head and neck cancers. This is at a randomized control trial looking at cisplatin and gemcitabine versus the standard of care at the time, which was cisplatin and 5-FU. This did show an improvement in median overall survival of 22 months versus 18.6 months, and is generally an easier to administer and well-tolerated regimen. And this would be the preferred standard of care in patients with metastatic, incurable nasopharyngeal carcinoma. For the remainder of head and neck cancers, since the 1990s, cisplatin and 5-FU have been the standard of care. This is given as 100 milligrams per meter square of cisplatin, and 5-FU given on days 1 through 5 at 1,000 milligrams per meter square, given every 3 weeks. The seminal trial that led to this regimen was a SWOG trial, and this compared to actually 3 different regimens, the cisplatin and 5-FU as mentioned, a carboplatin-containing regimen with 5-FU, or methotrexate alone, which had been a regimen used at the time. This 3-arm trial did not give us statistical differences in overall survival, but did give some descriptive analysis. Namely, the objective response rate with cisplatin and 5-FU was 30% versus 21% with carboplatin and 5-FU versus only 10% with methotrexate. Looking at the overall survival, this was 6.6 months with the cisplatin 5-FU, 5 months with carboplatin 5-FU, and 5.6 months with methotrexate. Once again, not statistically studied due to the study design, but had added to pre-existing literature and other trials that showed the cisplatin was still the preferred agent in this setting, as it did appear to have better overall outcomes compared to carboplatin and was better than single-agent methotrexate. A follow-up comparative trial looked at cisplatin and taxane compared to cisplatin and 5-FU and found similar outcomes with objective response rates at 27 versus 26%, and median overall survival in this trial was 88.7 in the cisplatin taxane arm versus 8.1 in the cisplatin 5-FU arm, which did not meet statistical significance. We have not had strong trials directly comparing a carboplatin regimen versus a cisplatin regimen. The first major study to show actual improvements in overall survival compared to this regimen was published in 2008 by Vermoken et al. In the New England Journal. And this is using what has been coolly named the extreme regimen. And this study used the standard cisplatin and 5-FU, and in the experimental arm also incorporated cetuximab, given as 400 milligrams per meter squared. Of note, in this study, they did allow for at provider's discretion to substitute cisplatin for carboplatin with an AUC of 5. And this was a randomized controlled trial looking for superiority in overall survival. Approximately 215 patients were randomized in each arm. These patients did not include nasopharyngeal carcinoma. 82% were under the age of 65, and the majority got cisplatin, with 67% in the experimental arm and 61% in the control arm. The study did meet its primary outcome and improved overall survival by 10.1 months versus 7.5 months, with a hazard ratio of 0.8. And looking at subgroup analysis, this overall survival benefit was only seen in the cisplatin-containing arms. This was fairly toxic compared to the non-cetuximab arm, with increased risks of rash, increased risk of sepsis. Sepsis was 9% in the cetuximab arm versus 1% in the control arm, and also an increased risk of cardiotoxicity. Of note, the study did not allow for crossover, so patients who progressed on the control arm were not allowed to get cetuximab. And this leaves the question of, is this really showing improvements in survival, or could these patients have benefited if they had cisplatin 5-FU and then on progression got cetuximab? And that question, unfortunately, has not been answered to date. The issue of crossover is not an uncommon one, especially in industry-sponsored trials. And it's always important to be mindful of whether or not patients are mandated to receive a drug upon progression or not, as this can affect your interpretation, especially if this drug has already shown efficacy as a single agent, as cetuximab had. More recently, as with many of our cancers, we've seen immune checkpoint inhibitors finding a way into this disease site. This has been an area of high interest because, as we recall, immune checkpoint inhibitors do seem to be greater efficacy in tumors with greater mutational burden, such as lung cancers and melanomas. And head and neck cancers are certainly one of these cancers, as they do have a very high mutation burden. So this was studied in the first line setting with the Keynote 048 trial. Once again, not including patients with nasopharyngeal carcinoma, but all other head and neck squamous cell carcinomas. Inclusion criteria for this trial required recurrence greater than 6 months from any chemotherapy. And this trial randomized patients 1:1:1 to either pembrolizumab monotherapy, pembrolizumab plus cisplatin or carboplatin and 5-FU, or to the extreme regimen, once again allowing for cisplatin or carboplatin as per provider discretion. This study stratified patients by PD-L1 TPS score, greater than 50% or less than 50%, P16, and ECOG status. Primary outcomes were initially overall survival and progression-free survival, looking at the pembrolizumab versus extreme regimen. This actually was an amended study, and the final statistical plan was very complicated. It had 14 hypotheses, so 14 different comparisons were assessed in sort of a sequential manner. Understandably, the more times you test things, the more diluted your power gets. And I find it was very difficult to read the statistical plan. They actually had to put it in the appendix rather than the major paper. And even more difficult to present coherently in a time-limited manner here. So I highly recommend to review this on your own. But we will try to look at some of the major questions here, which was the pembrolizumab alone better than the extreme regimen? Was pembrolizumab and chemotherapy better than the extreme regimen? And they did test for superiority in both of these hypotheses in patients with a CPS score greater than 20. So recall they stratified them based upon TPS score, but then when it came to amendment time, they began to look at the CPS score, looking at a score of 20% being the cutoff. I'm not sure why 20% was selected instead of 30 or 40 or what have you. It was not clarified in the protocol. Other major hypotheses included non-inferiority of the pembrolizumab and chemotherapy versus extreme regimen in the total population, and superiority of the pembrolizumab and chemotherapy versus extreme regimen for PFS in the total population. They did not compare the pembro alone versus pembrolizumab and chemotherapy. So looking at these patients, 43% did have a CPS score greater than 20%. 85% had a CPS PD-L1 score greater than 1%. This was a primarily male population, making up about 75% of the patients. 25% from North America, 29% from Europe. And in this study, approximately 60% in each arm of the chemotherapy arms received carboplatin. So a little bit lower than what we saw with the extreme trial. Looking at the CPS greater than 20% cohorts, pembrolizumab was superior to the extreme regimen with a hazard ratio of 0.6. The median overall survival was 15 versus 10.7 months. This also showed superiority in the initial publication looking at patients with a CPS greater than 1% with a hazard ratio of 0.8 with a median overall survival of 12 versus 10 months. But when you do look at the Kaplan-Meier curves for that population, so the CPS greater than 1, you did see some patients in the pembrolizumab arm having an early increased risk of death that eventually seemed to level off, but this is what we typically see with immune checkpoint monotherapy, where the efficacy seems to be a bit delayed. So some patients have an early progression. Pembrolizumab alone did not meet superiority in the total population. When we look at the pembrolizumab and chemotherapy, in the CPS greater than 20% cohort, they did not make statistical superiority, even though the hazard ratio was 0.6 and median overall survival was 14.7 versus 11 months. And this was likely as a result of dilution of their power and allocation of more of their alpha to the pembrolizumab alone arm. They found in the total population there was improvement in overall survival with 13 versus 10.7 months. We did find that toxicity seemed relatively comparable between the pembrolizumab combination and the cetuximab containing combination. Understandably, pembrolizumab monotherapy was a less toxic regimen. There's far too many comparisons being looked at here to see whether or not cisplatin was superior to carboplatin. If you look at these cohorts, the focus was on CPS greater than 20, CPS greater than 1 in all populations. They did not initially do any analysis of the 1 to 19 or less than 1%. And this was eventually published in a post-protocol analysis, which I think is relevant because it certainly is important for us when we're deciding whether or not to use pembrolizumab alone. They found that in patients with the CPS less than 1%, looking at pembrolizumab alone versus the extreme regimen, the median overall survival was shorter. It did find in the CPS 1 to 19%, pembrolizumab alone did have a slightly increased overall survival of 10.8 versus 10.1 with a hazard ratio of 0.86, although statistical superiority could not be shown. Looking at the combination, pembrolizumab and chemotherapy, for PD-L1 less than 1%, statistical superiority for survival was not shown compared to the extreme regimen. However, in the 1 to 19% population, the overall survival did seem better. With a hazard ratio of 0.7, median overall survival was 12.7 versus 9.9 months. Of note, there's also been a phase 4 trial that's since come out looking at carboplatin, paclitaxel, and pembrolizumab and shown that this is a feasible combination. And depending on where you train, you may be more likely to see this rather than cisplatin 5-FU. I think the utilization of pembrolizumab is certainly showing to be a beneficial option for this patient. Unfortunately, the clinical trial is a little bit messy and makes it difficult to incorporate into clinical practice. There's probably another way that this could have been run where we could have some clear answers on certain PD-L1 cutoffs and what would be the best way to use, but the data is what we have right now. I think given the post-hoc analysis looking at the PD-L1 less than 1% group, I would not recommend pembrolizumab monotherapy in these patients and would likely choose either the extreme regimen, chemotherapy alone, or consideration of chemotherapy and pembrolizumab, although it did not look like there was a significant value for the chemotherapy and pembrolizumab in that group. For a CPS of 1 to 19%, it does look like the chemotherapy and pembrolizumab might be a bit better than the extreme regimen, so it would be maybe something we would lean towards there. Extreme regimen still would be an option if someone has a contraindication to pembrolizumab. If patient's not a candidate for chemotherapy, you could consider pembrolizumab alone, although the efficacy does seem to be less so than in the increased CPS group, which would be like greater than 20%. In those patients, I would likely prefer pembrolizumab alone, but would certainly consider chemotherapy and pembrolizumab if an early response is necessary, such as patients with rapidly progressive or highly symptomatic disease, as we have shown that the immunotherapy alone does not have that quick onset. As an aside, there have been attempts to look at immune checkpoint inhibitors in nasopharyngeal carcinoma, and so far these have not shown improvements in overall survival, but there are some early reports of these studies that have shown increased progression-free survival, so we may see these work their way into the regimens as the data continues to mature. After progression on the first-line regimen, your options are going to be typically single-agent systemic therapy. If you have not used an immune checkpoint inhibitor in the first line, there is evidence to support these in the second line, agnostic of a PD-L1 score, although I would caution for patients with low PD-L1 score may be less likely to benefit. Cetuximab monotherapy is an approved option and has an objective response rate of 11%. Methotrexate is old, tried and tested, and could be considered. Gemcitabine monotherapy could be considered, as well as taxanes have not yet been used in the metastatic setting for these patients. And as always, being mindful of clinical trial options may open up some additional things to consider. All right, so try to tie together some bottom lines here. Locally advanced head and neck cancer has a high risk of recurrence, and often due to extensive disease invasion, surgery may be highly morbid, and concurrent chemoradiation using a cisplatin-based chemotherapy has emerged as being as good as surgery alone and potentially allowing for organ preservation. For patients who are not candidates for cisplatin, either radiation alone or potentially a carboplatin-based or taxane-based concurrent chemotherapy regimen could be considered. The role for induction chemotherapy remains controversial. It has shown an overall survival for nasopharyngeal carcinoma. However, there has not yet been a convincing trial to show overall survival in non-nasopharyngeal carcinoma. The only trials that have shown improvements over overall survival have been showing an intensification of induction chemotherapy, adding a taxane to cisplatin and 5-FU alone. And this, along with the MACH-NC meta-analysis, have shown decreased local and distant failure, have led for ongoing interest in using this. Depending on where you work, you may see induction chemotherapy used frequently or maybe not so much. If a patient is a candidate for induction chemotherapy, a more intensified platinum, 5-FU, and taxane-containing regimen seems to be the most efficacious to date. In nasopharyngeal, we would typically use cisplatin and gemcitabine. In either case, 3 cycles would be used prior to the concurrent chemotherapy and radiation. In the metastatic setting, the current standard of care would be a pembrolizumab-containing regimen, which may be considered as pembrolizumab alone with a CPS score of greater than 20%, with less certainty with a CPS score of 1 to 20, where either a pembrolizumab plus chemotherapy regimen could be considered, or in patients where concerns about chemotherapy toxicity are significant and disease burden is not too high, we may try a course of pembrolizumab alone. In patients with a CPS score of less than 1%, we would not recommend pembrolizumab alone, and to consider either chemotherapy alone, extreme regimen, or chemotherapy plus pembrolizumab, keeping in mind that the extreme regimen is highly toxic, so it would have to be in the most fit of patients. After progression on first-line multi-agent regimen, further refractory therapy would include sequential single-agent systemic therapy. Very important to incorporate palliative care, supportive care, and symptom management, as with ongoing progression, symptom burden can really become a major quality of life impairment for these patients. All right, thanks for following along, and we are going to next move into the GU malignancies, and Ryan Quinn will be rejoining next discussion. Feel free to reach out and give us any feedback through our email or Twitter. We're happy to hear all opinions, and if you have been following on the podcast app, such as Spotify or Apple Podcasts, please put a review. Helps other people find the podcast. Thanks so much.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
The opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.